Thank you very much for inviting me to give this talk. I understand that it was a talk that was requested from a patient group, so I'm doubly honoured to have been invited and really pleased that people are interested in this topic. So as Ralph said, my name's Claire Sharpe. I'm a kidney doctor at King's College Hospital, and I've been running a joint clinic with the haematologists at King's for about the last, I think it's now 18 years this clinic has been running. And it's for patients with sickle cell disease who have kidney complications. So I'm really going to talk a bit about my experience, bring in some cases that I've seen, and talk a bit about both the pathophysiology of how sickle cell disease impacts the kidney and what we can do to mitigate that. So I understand that this is a mixed audience, nurses, doctors, patients, allied health professionals. So I hope I've pitched my talk right, but if I say anything that people don't understand, then please do ask questions at the end, and I'm happy to explain anything. So let me start off by introducing you to Mr. O, who was one of the very first patients I met when we started this clinic. I saw him back in 2005, and at that time he was 43. He was a Nigerian of Nigerian heritage, but he'd been in the UK for a number of years. He has HBSS, sickle cell disease. And at the time I saw him, he had quite advanced chronic kidney disease with a creatinine of 212. Now, back in 2005, we hadn't even started calculating estimated GFRs. We were focusing on just creatinine, but that's quite severe chronic kidney disease at that time. He also had a lot of protein in his urine with a protein's creatinine ratio of 790. In his past medical history, he had high blood pressure, he had bilateral avascular necrosis of the hips, he'd had pulmonary emboli in the past, he'd suffered with leg ulcers. But worst of all, impacting his life were multiple admissions with frequent painful crises. And this is just a chart of what had happened to his kidney function over the preceding 3 or 4 years. Every time, this is a chart of his serum creatinine level. The two horizontal blue lines mark the normal range of creatinine. So you can see his kidney function, his creatinine had been above the normal range. So he'd had chronic kidney disease for the last couple of years. And it's bouncing about a bit because every time he came in with a painful crisis, he would have deterioration in his kidney function, and as he got better, it would get a little bit better. But over time, the sort of baseline of his kidney function was getting worse. So although he had acute kidney injury every time he came in with a painful crisis that would recover, his kidneys would never quite get back to as good as they were beforehand. And so he had quite rapidly progressive underlying chronic kidney disease. So why is it that the kidneys are particularly susceptible to damage in patients that have sickle cell disease? I think you'll all be familiar with the concept that sickle cell disease is really a disease that affects small blood vessels. And those small blood vessels can be anywhere in the body. Sometimes when a small blood vessel is blocked by sickle cell disease, when it's impacted, you get pain, but you don't always get pain. And if you look at this picture of the kidney here on the left, you can see how intricate the vasculature in the kidney is. Lots and lots of tiny blood vessels that perfuse the kidney. So just from that picture alone, it's not difficult to understand why the kidney might be a target for damage in patients with sickle cell disease from vaso-occlusion. The other reason why the kidney is particularly susceptible to kidney damage is it's effectively an organ of two halves. You have the cortex, which is the outside bit of the kidney, which wraps around the medulla, which is the central part of the kidney. And although the kidney gets a high blood supply, it gets about 20% of the cardiac output of all the blood that the heart puts out, 20% goes through the kidney, so that the kidney can clean the blood of waste products. Most of that blood just goes around the cortex of the kidney. It goes around the outside where the filtering of the blood happens, and very little of it actually makes it to the centre of the kidney. So in the middle of the kidney, with the blood vessels that go dip down into the middle of the kidney, there's a very low oxygen tension. The middle of the kidney is quite acidotic. So it's actually an environment that would trigger the sickling of red blood cells in people with sickle cell disease. So although the outside of the kidney is fine, the inner bit of the kidney is a very harsh environment for a red blood cell. This is called a micropuncture study of what a normal kidney looks like. So if you inject dye, this is a kidney that's been taken out at autopsy. If you inject dye into the blood vessels in the kidney, this is what they look like. So you have lots of blood vessels, capillaries going around what are called the glomeruli on the outside of the kidney. But those lines which are radiating into the center of the kidney are those blood vessels that go down into that hypoxic and acid part of the kidney. This is what a normal kidney looks like, and this is the same study done from someone who's had sickle cell disease. This is back in the 1970s. In fact, this was a 5-year-old child. So even by the age of 5, you can see that there's been really marked damage to the blood vessels in the kidney, and in particular, those blood vessels that radiate into the center of the kidney have all been obliterated. So what impact does that have on someone with sickle cell disease? How does that manifest itself clinically? Well, interestingly, has been observed in children with sickle cell disease that because they are anemic and they're young and they're healthy and they have very good hearts, they actually have a higher cardiac output. They pump blood around the body at a much higher rate than someone without sickle cell disease or anemia. That extra blood goes through the kidney, and that increases the clearance of the waste products from the blood through the kidney. So when you're measuring kidney function in children with sickle cell disease, and we measure that through something called the estimated glomerular filtration rate, a normal GFR might be 120 mils per minute. In children with sickle cell disease, it's not unusual for it to be 200 or 300 mils per minute. So they appear to have super good kidney function when they're young. And that leads to a phenomenon called hyperfiltration. And it's this hyperfiltration that over time can cause damage to the kidneys. So the filtering unit in the kidney called a nephron, and we have about 1 million nephrons in a single healthy kidney. We each have 2 kidneys and each kidney has about 1 million nephrons in it. The red blob that you can see here is the glomerulus, and that is where the blood is filtered to filter out waste products and water that we drink that we need to get rid of in the urine. And you can think about these glomeruli, these nephrons, as being workmen that have a piece of work to do. So if you imagine each of these workmen in this picture is a nephron, and they're all putting their effort into holding up this really heavy wall. They're all doing this piece of work. If you increase the work that they have to do, if you increase the blood flow through the kidney, you're effectively making this wall heavier. And so the amount of work that each of these nephrons has to do, each of these workmen, gets harder and harder. And eventually, over time, this increased workload leads to burnout in some of these nephrons. The work just gets too much for them. They scar up and they cease to be functional. But as you remove these nephrons, these workmen, from holding up the wall, you can imagine the work then is spread around the remaining nephrons, the remaining workmen, so the work increases further. So you get this vicious cycle of the workload increasing, you get drop out of nephrons due to sclerosis or scarring. That increases the work on the nephrons that are remaining, and over time you have this vicious cycle of gradually losing nephrons to scarring. So this is how hyperfiltration, this increased blood flow through the kidney, leads to chronic kidney disease over time. And if you look at this, this is just a snapshot of our patients in the clinic at King's, according to age. So if you look at their eGFR, which is roughly their percent kidney function, in the young group, you can see they've got super duper kidney function, some of them up to sort of 250, 280 mils per minute, where 100, 120 would be more normal. But as they age, and this happens in everybody to a certain extent, but this is more rapid in patients with sickle cell disease, as they age, the GFR falls. And you can see that blue line there set at 60 is the level where we measure, we really say people have developed chronic kidney disease once it drops below the level of 60. So you can see from about the age of 30, 35 onwards, people's kidney function has begun to drop below that blue line. So between about 5 and 10% of people, sometimes more in some cases, as they age, develop this chronic kidney failure syndrome. And that tends to be people in their 30s. So from the 4th decades onwards, you can see this decline in kidney function. Although the kidney function may decline in everybody. Not everybody reaches levels at which we would declare them as having kidney disease. The other phenomenon about this hyperfiltration is that it causes high blood pressure in that glomerulus, in that filtering unit. And when the blood pressure gets too high, you can imagine a filter paper. If you fill up some filter paper with sand and water mixture and you wrap it up tightly to increase the pressure, to increase the filtration, eventually the holes in that filter will expand and get bigger. Now, normally the holes in the filter in the kidney are very small and they let through water and small waste products like creatinine and urea and things that we don't want to necessarily keep in the blood. But as those filters get damaged and stretched through hyperfiltration, the holes get bigger and they start to let proteins through. And then protein starts to appear in the urine. And that's an early sign that this process of hyperfiltration has been happening. Now, the kidney function may still be very good at this stage. It's clearing those waste products like creatinine. But you can see as protein begins to appear in the urine, that's a sign that some damage has been done. Paradoxically, this high blood flow that goes around the kidneys in the younger people with sickle cell disease can actually increase the rate at which some of these waste products appear in the urine. So most of them are filtered at glomerulus, but further down in the tubules of the nephron, you can sometimes further secrete these waste products into the urine. And creatinine particularly is the one that we use to measure kidney function. And this can be secreted by the proximal tubule into the urine when the blood flow in the kidney is high. And that actually makes our normal measurements of kidney function slightly unreliable in people with sickle cell disease because it tends to overestimate how well their kidneys are working. If you cast your mind back to that picture that I showed you with the loss of the blood vessels in the center of the kidney, it's the medulla, the center of the kidney, where the concentration of urine occurs. And as you lose those functional blood vessels in the center of the kidney, then the kidneys lose their ability to concentrate urine properly. And that's what leads to what's called hyposthenuria, or bedwetting at night, and also having to go to the toilet to pass lots of urine during the day. And this is why it's really important that children in particular and adults drink plenty of water to keep themselves well hydrated, because their kidneys lose the ability to concentrate urine. That's usually reversible with blood transfusion up to about the age of 10, but over the age of 10 that becomes irreversible because those blood vessels have been lost, and often patients will complain of needing to get up at night to pass urine. We also know that other parts of the nephron that are responsible for maintaining the right acid environment in the blood and the right potassium levels can be impacted in sickle cell disease. So patients, particularly when they become unwell, are prone to being very acid in their blood and very prone to having high potassium levels, which can be dangerous if not monitored and treated carefully. Seeing blood in the urine happens intermittently. Some people it never happens, some people it happens quite frequently. That can be as a result of blockage of one of those small blood vessels in the inner part of the kidney. Sometimes it's just visible blood in the urine. It's not associated with any problems or any pain, and it will clear up by itself. Sometimes it can be associated with the passing of a big clot or a slough of tissue down the tube, the ureter that leaves the kidney, and that can be really painful, a bit like passing a kidney stone. And we've noticed in our clinic, when we were doing scans, routine scans of patients with protein in the urine and kidney disease, we began to pick up that patients with sickle cell disease had lots of simple cysts in their kidney. Now, the cysts are just little fluid-filled bags. They don't in themselves cause any damage. But we were noticing them on the scans, and we wanted to know whether they're more frequent in patients with kidney disease, with sickle cell disease. So we compared the scans from a group of patients with sickle cell disease, 198 patients with sickle cell disease, and we compared them to 180 control patients who were ethnically matched and age matched. And you can see that patients with sickle cell disease are 3, 4, 5 times more likely to have cysts in their kidneys, and this incident increases with age. Now, we don't know whether that means anything. Does it mean they're going to get chronic kidney disease? Not necessarily, but they can sometimes be confused with patients that have another condition called polycystic kidney disease. where the cysts are very much associated with progressive chronic kidney disease. So it's just something to bear in mind. Just because the patients with sickle cell disease may have multiple cysts in their kidneys doesn't mean they have polycystic kidney disease. So as I pointed out, probably about somewhere between 5 and 15% of people with sickle cell disease, as they age, as they become older adults, will develop chronic kidney disease, but it's not everybody. So what is it that means some people get chronic kidney disease and other people don't? Well, not surprisingly, those people who have severe phenotypes of sickle cell disease, those as I've shown with Mr. O, who have frequent admissions with painful crises and acute kidney injury, more prone to getting chronic damage and scarring. And we've also shown that those people that have high rates of hemolysis and particularly low hemoglobins are more likely to develop protein in their urine and develop chronic kidney disease. There are some genes other than the gene that causes sickle cell disease, but co-inherited genes that can impact on whether someone's likely to get chronic kidney disease. We know patients that co-inherit alpha thalassemia are actually slightly protected from getting proteinuria and chronic kidney disease, whereas there are other genes such as BCL11A, which controls the production of fetal hemoglobin, and APOL1, which is a gene that protects against sleeping sickness in Africa. Both of those different types of those genes can increase the risk of getting chronic kidney disease. And this paper back in 2017 by Sharpe et al. looked at their cohort of patients, genetically typed all their patients, and looked at whether those that developed progressive chronic kidney disease, how those risk of those 3 genes put together impacted their progression of chronic kidney disease. And they were actually able to demonstrate that if you do genotype patients, you can put them into these 3 categories of low risk, intermediate risk, and high risk, depending on how many of those different gene mutations they hold. And finally, unfortunately, people with sickle cell disease are not immune to getting chronic kidney disease due to other causes. So high blood pressure is a very common cause for chronic kidney disease. People of African ancestry are more prone to getting hypertension, tends to run in families. And we know that the combination of high blood pressure and sickle cell disease significantly increases the risk of chronic kidney disease. Diabetes is another very poor risk factor for chronic kidney disease. Autoimmune disease, such as lupus, which can be more common in people from particular ethnicities, and some viruses which can come through bloodborne viruses can cause chronic kidney disease. So this is just to show you a chart, just a couple of examples of patients who have sickle cell disease and another cause of chronic kidney disease. This was a young woman. This is her creatinine graph, and again between the 2 straight lines is normal. Back in 2009 she had normal kidney function, but she had very poorly controlled blood pressure. It was very difficult to control her blood pressure, and you can see over a 5-year period her kidney function got rapidly worse and she ended up on dialysis. And she was only about 25, 26 when she ended up on dialysis. And this was another young woman that unfortunately had type 1 diabetes that she developed when she was about 10, and she rapidly developed chronic kidney disease over about a 4 or 5 year period. And she ended up on dialysis when she was 19. So having the combination of 2 diseases can really accelerate that progression into end-stage kidney disease, kidney failure. So what are our treatments for what we call sickle cell nephropathy? Sickle cell nephropathy just means kidney disease. So how do we treat patients who have or are at risk of getting sickle cell disease related kidney disease? Well, we can treat the underlying cause. We can treat the sickle cell disease, and you'll all be familiar with hydroxyurea, also known as hydroxycarbamide. We know very well that that's an excellent medication for patients with sickle cell disease. It reduces frequent painful crises. It's safe and well tolerated in children. And over time, increasing numbers of patients are taking hydroxycarbamide. There haven't yet been definitive evidence from large-scale clinical trials that it prevents or treats sickle cell nephropathy, but there's quite a lot of anecdotal evidence that it's good. Transfusion therapy, either intermittent or regular, top-up or exchange, we know can manage many of the symptoms of sickle cell disease. Again, no hard and fast evidence that it's good for treating sickle cell nephropathy, but lots of observational studies and lots of anecdotal studies that patients' kidney disease may be stabilized or prevented if they're on transfusion. Hemopoietic stem cell transplantation, we know, is a cure. I've written here in childhood because most of it happens in children, but it is now starting to happen more in adults. We know that is a sort of cure for sickle cell disease, if you like. And so it is logical to assume that it would treat or prevent kidney disease. But again, there are no large studies to demonstrate that. And then on the other side of the equation, we have treatments for chronic kidney disease, so chronic kidney disease is just a process of scarring of the kidney. Some disease causes damage, that could be sickle cell disease, but it could be something else. And that triggers a process of the scarring and hyperfiltration. So hyperfiltration is not limited to sickle cell disease, it's quite marked in sickle cell disease, but it's a common process. So we can treat that process of scarring in the kidney regardless of whether it comes from sickle cell disease or not. We know adequate hydration is really important. We know control of blood pressure, if the blood pressure is high, makes a huge difference. And there are really large-scale studies over decades in patients with chronic kidney disease of all causes to show that managing blood pressure has a really important positive impact on the progression of chronic kidney disease. ACE inhibitors, or angiotensin receptor blockers, are two classes of drug which are used to treat high blood pressure, but they specifically also focus their impact on the glomerulus, those filtration units in the kidney, and they lower the pressure inside the glomerulus. So they reduce protein in the urine, and they reduce that high pressure that causes that damage over time. And we know from studies on people with all-cause chronic kidney disease that ACE inhibitors and ARBs are very good at slowing progression of chronic kidney disease. When patients develop chronic kidney disease, the kidneys not only stop or lower the rate at which they can clear waste products from the blood, but they also stop producing this really important hormone called erythropoietin. And erythropoietin is produced by the kidneys, but it acts on bone marrow to drive the bone marrow to produce red blood cells. So as people develop chronic kidney disease, their EPO, erythropoietin levels drop, they become more anemic. We can treat that anemia by replacing erythropoietin through injection therapy. And finally, if someone's kidney function fails altogether, so that their kidneys don't have enough function left to clear the waste products and keep them well and alive, then dialysis treatment and transplantation can replace the function of the kidneys. This is just a little bit of data on ACE inhibitors and ARBs. As I've said, we've shown from multiple studies on patients with all-cause CKD that they're beneficial, but this is one particularly showing impact in patients with sickle cell disease. And interestingly, it shows that in patients who have protein in the urine, whether it's macro, that means high levels of protein, or micro, which means low levels of protein, and the black line is just an average of the two. If you give an ACE inhibitor, the amount of protein in the urine is reduced, and that's a sign that the pressure in the kidney has been reduced, which is a good thing. And if you look at visit 4 here, even after in this study they stopped the ramipril, which is an ACE inhibitor, the beneficial effect was maintained for a while. So that implies that these ACE inhibitors are what we call disease modifying. They have the ability to impact the kidney function in a good way even after you stop taking them. Now, stopping that good benefit will wear off after time, so we don't recommend people stop taking them, but it's a good indication that it's doing good to the kidney. So a little bit about erythropoietin, because I often get asked, is erythropoietin safe in patients with sickle cell disease because it's driving the bone marrow to make more red blood cells? And does it work? Does it help to bring up the hemoglobin level? Well, I'm afraid the answer is yes and no. It works in some people, but not in everybody. And there's no way in really predicting who it's going to be benefiting. So these are data from a patient 1 who was a woman with who was a Jehovah's Witness, and so did not want to have any blood transfusions. She also developed chronic kidney disease. And in this top graph, the green line is her creatinine level. So you can see from about 2008 onwards, her creatinine started to rise quite rapidly up until she became dialysis dependent. If you look at the bottom graph, the blue line is her hemoglobin. As you can see, as her kidney function got worse, her hemoglobin dropped. And that's because she was losing production of her own erythropoietin. We commenced her on erythropoietin injections. It had no impact on her hemoglobin. And if you go back to that top graph, that blue line, it had no impact on her baby red blood cells, her reticulocyte count. And unfortunately, this lady passed away very anemic, and EPO did not help her hemoglobin at all. But this is another patient, also Jehovah's Witness, so also decided not to have blood transfusion. Similar scenario, she developed chronic kidney disease. If you look at this green line in the top, her creatinine started to go off. Her hemoglobin fell quite rapidly. We started her on erythropoietin, and her reticulocyte count in that top graph in the blue line was excellent. Her hemoglobin bounced back up, and she maintained a good hemoglobin for a significant amount of time on erythropoietin injections. So although patients with sickle cell disease often require quite large doses of erythropoietin when they develop chronic kidney disease, we don't really know whether it's going to benefit them or not unless you try and see. So a little bit about hydroxycarbamide. As I said, there aren't any large-scale clinical trials to tell us whether hydroxycarbamide can prevent people getting chronic kidney disease when they have sickle cell disease. But this is a study called the Hustle study, which was done in children over 3 years, and it treated them with hydroxyurea, and it looked at all sorts of impacts of that. And this is just looking at their glomerular filtration rate. Now, if you remember, I said in children, the GFR tends to be above normal. That's what causes the hyperfiltration, and that's what's causing the damage. So that very high GFR is what's causing the damage. And in children that were treated with hydroxyurea over time, on average, their GFR fell back towards more normal levels, and that's felt to be a positive thing. This was another study called the Twitch study, looking at the impact of transfusion. So taking a cohort of, again, children who've been put on transfusion, usually because of their risk of stroke. And again, looking at their GFR, comparing transfused cohorts with untransfused cohorts. And those patients that received transfusion had less protein in their urine and a lower GFR, again, suggesting that regular transfusion can lower that hyperfiltration, prevent chronic kidney damage. So let's come back to Mr. O. Just to remind you, I first saw him in 2005. He had quite advanced chronic kidney disease, lots of protein in his urine, lots of complications from sickle cell disease, and that history of frequent admissions with painful crises and this worrying decline in his kidney function. When we saw him at the beginning of 2005, we started him on hydroxyurea and an ACE inhibitor. And that actually completely revolutionized his life. It stopped his frequent painful crises. Having had 4 or 5 admissions a year, he had no admissions over 5 years after starting hydroxyurea. And he really was a new man. And alongside that, you can see not only did his kidney function stabilize, it actually started to improve, and his proteinuria came down massively. And he was so much better that in 2010 he got married, and he decided he wanted to have a family. And as many of you will know, it's not recommended to father a child whilst you're taking hydroxyurea. And his wife was very keen to have a baby, so he decided to stop taking the hydroxyurea. And straight away, his painful crises came back. Really within a month or two, his painful crises came back. His kidney function rocketed off because he was having acute kidney injury. He realized very rapidly that he couldn't remain well off of hydroxyurea, and restarted it, and things started to settle down again. You can see he has a really good response to his hydroxyurea. So this bottom pink line is his hemoglobin, but the top line is his fetal hemoglobin. And you can see that his fetal hemoglobin responds really well to hydroxycarbamide. That's diluting down his S hemoglobin, stops his painful crisis. And when he stopped the hydroxyurea, his fetal hemoglobin dropped suddenly, and when he restarted it again, it bounced back up. So he responded again. So he remained well for another couple of years, taking his hydroxycarbamide. But by this time, his wife was really anxious to have children. He really wanted to have children, but we weren't going to make the same mistake again by taking him off his hydroxycarbamide and doing nothing else. So we took him off hydroxycarbamide and put him on regular exchange blood transfusion. So the blue line, which is percent hemoglobin, dropped with the exchange transfusion, and you can see this dogtooth pattern is typical. Between each transfusion episode, his HbS would rise, he'd be transfused, and it would drop again. The pink line is his creatinine, his EGFR. So this is his percent kidney function, and although his percent kidney function is really quite poor at this time, between 25 and 30, it remains really stable over several years, despite having a total hip replacement in 2012. And during this period, his wife gave birth to twins, and it was a great celebration. So it was a great outcome. But as does occur with long-term transfusion, his ferritin, his iron loading, went up. Even though he was having exchange blood transfusion, he was effectively getting a bit topped up, and his ferritin levels started to rise. And some of the treatments we have for high iron levels, such as Xjade, can be toxic to the kidneys, so it can be quite difficult to treat. So after his wife had twins, they decided that was it. That 2 in 1 go was fantastic. And he stopped the exchange blood transfusion and went back on hydroxycarbamide, which had worked really well for him. But while he was on exchange transfusion, he'd got used to having a hemoglobin of around 100 and 110. And when he went back on hydroxycarbamide, although he didn't have frequent painful crisis, his total hemoglobin dropped down to about 75, and he began to feel symptomatic from his anemia. So we started him on erythropoietin, and his hemoglobin came up to a comfortable level between 80 and 90. And he remained very stable like this for several years on hydroxycarbamide and on EPO. Remaining very tired, but only because he had young babies to look after at home. But as I pointed out, he has quite advanced chronic kidney disease at this stage, and we needed to talk to him about the future and what happens when the kidneys fail completely. So there are 3 options when the kidneys fail. There are 2 types of dialysis, hemodialysis and peritoneal dialysis. There's kidney transplantation, and there's what we call conservative management. Conservative management is not intervening with a kidney replacement therapy, so no dialysis or transplantation, but just managing symptoms of chronic kidney disease as they arise and recognizing that that's a sort of end-of-life type care. And for some people, conservative management is the right thing to do. But in young people like Mr. O, we would certainly put someone forward for dialysis with a view to kidney transplantation. So hemodialysis, what happens? So hemodialysis patients come up to hospital 3 times a week for 3 or 4 hours. They receive hemodialysis usually through a fistula or a line, where this machine you can see here next to this gentleman, the blood's coming out of his body, going through the filter that acts like a kidney in the machine, clears waste products and water from the blood, and the blood's returned to the patient. Some patients have a hemodialysis machine installed at home, and they can learn how to do it themselves at home with technical support. Peritoneal dialysis is quite different. A tube is inserted in a small operation into the abdominal cavity, and patients do the dialysis themselves at night at home. It doesn't involve any blood. There's a dialysis fluid, which the machine pushes through the tube, and it sits in someone's abdominal cavity overnight. That sucks water and waste products out of the patient, and then that fluid is drained out and some more fluid is drained in. So this is done at home. Patients manage it themselves, and they just come up to clinic once every 6 or 8 weeks. Kidney transplantation is for people who are fit enough to undergo surgery and to tolerate the anti-rejection medication that they have to have. When someone has a kidney transplant, you don't take out their normal kidneys. Although their normal kidneys have stopped working, they're on the whole not doing any harm by being there. So a third kidney is plumbed in around the groin area. It's plumbed into the blood vessels that go down to the leg, and it's plumbed into the bladder. So after a kidney transplant, someone will have 3 kidneys in general. Kidneys can be donated by someone who's died, and that's called cadaveric kidney, or sometimes a kidney can be donated by a friend or a relative, and that's a living donor. So what's the prognosis for people that end up on dialysis? And this is particularly looking at hemodialysis, if people have sickle cell disease, and how does that compare to people who are on dialysis for other reasons? Well, unfortunately, this is a big French study demonstrated that people who are on dialysis because of sickle cell disease actually have a worse outcome on dialysis than people who are there for other forms of chronic kidney disease. Over a 5-year period, they're much more likely to die. They get infectious complications, they get blockages of their dialysis access. And not only are they worse off on dialysis, but they're actually much less likely to receive a kidney transplant. But in those patients that do receive a kidney transplant, the kidney transplant function is good. So after 5 years, 75% of them are still working. But it's not quite as good as it is for patients that don't have sickle cell disease, in whom 85 to 90% of kidneys are still working after 5 years. The life expectancy of patients who have a kidney transplant is much better than it is for patients that are on dialysis. But again, it's not quite as good as patients who have a kidney transplant that don't have sickle cell disease. And this is a recent study that's come out of America, which shows something quite similar to what I've shown you from the previous studies. And just to highlight what this quite complicated slide shows, it basically says that when patients get a transplant with sickle cell disease, they do well, but they wait on the waiting list much longer, and they're much less likely to get a kidney transplant. And that's for a number of reasons. They have many intercurrent illnesses, and people need to be well and stable in order to receive a kidney when one becomes available. And there may be fears around transplanting patients with sickle cell disease because of the transplantation process itself can be so risky. So what happens during cadaveric kidney donation and transplantation? Well, a donor who's generally on an intensive care unit passes away. The donor and the family have made the decision to donate their organs. And that can be from someone who's called DBD when they have a brainstem death, or DCD when they have a cardiac death. And we use both types of donors. In the UK, an institution called NHS Blood and Transplant then organised the retrieval of the organs that are going to be donated, whether it's kidneys, heart, lungs, whichever organs are donated. A retrieval team goes and retrieves all of these organs. They're then put on ice, sent around the country to the name that's next on the waiting list that comes up for those organs, and that can be Inverness to London, it can be from one end of the country to the other. Eventually, it's given the recipients called into their home institution, and the transplantation happens. And what's called the cold ischemic time, which is the amount of time that the organ's on ice for, can be anywhere between 8 and 24 hours. Then during the process itself, as I've explained, the kidney's plumbed in the groin area. This is what a kidney looks like just before it's plumbed in. And this is what a kidney looks like just after the clamps are released from the blood vessel. The blood flows into the kidney, it pinks up, and it starts making urine straight away. And it's actually a very exciting thing to watch. But as you can imagine, if you take an ice cold kidney and put blood through it from someone with sickle cell disease, if they have a high level of HbS in their blood, which can be 80 or 90% of their hemoglobin if they've not been transfused, that freezing cold tissue, which is acidotic and has very low oxygen levels in it, can cause a very acute sickling reaction, which can stop that kidney working. So it's not uncommon when we've looked back over outcomes from kidney transplants for patients to have had what's called delayed graft function. The kidney goes into an acute kidney injury immediately after the operation, and then it doesn't work for the first 5, 10, 15 days. Often they pick up eventually, but it's not good for the kidney to go through that process. So one of the questions we've asked ourselves is, does regular exchange blood transfusion help? If we can exchange patients who are on the waiting list so that their HbS percent is really low, and when they're called in for a kidney transplant, they're ready to go without that risk of an acute sickling crisis in the kidney? Or can it cause can it increase the risk of rejecting that kidney? Because by giving people lots of transfusion, you're exposing them to lots of antigens from other people that can make them produce antibodies, which can then reject the kidney. And in people without sickle cell disease, we try and avoid blood transfusion because of this increased risk of rejection. So we really didn't know whether transfusing people a lot to make them better for the operation is going to help, or whether it's going to increase their risk of rejection. So we did a study. It wasn't a randomized study, it was a retrospective study, just looking at the outcomes of people across London for all kidney transplant units in London over a 15-year period, everyone with sickle cell disease who'd received a kidney transplant, and just looked at those that had had blood transfusions, exchanged blood transfusions, and compared it to those that hadn't. And the group actually split about 50-50. So there was about half the patients, about 36 patients in all, about half of them had exchanged blood transfusion and half of them hadn't. And when we looked at both patient and graft survival, and we looked at how well the kidneys were working at 1 and 5 years, we were able to show that those that had exchanged blood transfusion at some point, and that was either before or during or after the operation, they had better kidney function and their graft was more likely to be working at both 1 year and 5 years. And when we looked at rejection rates and the whether people were likely to get sickle cell crisis post-operatively and whether they're likely to develop what we call donor-specific antibodies, there was no increase in donor-specific antibodies, but not surprisingly, those patients that had no transfusion were much more likely to have recurrent sickle cell nephropathy, kidney damage, and interestingly, and to our surprise, were also more likely to get rejection in their kidney. Now, this is not statistically significant. The numbers are low. It was retrospective. It's not a randomized trial, so you can't be definitive. But I think what this showed us is that we were reassured that we weren't triggering rejection in our patients by giving them exchange blood transfusion, and we're likely to make their kidneys last longer. And when we compared both patient survival and transplant survival, not surprisingly, the transplant survival, having showed what we showed previously, was better in those patients who received transfusion. But strikingly, patient survival was much better in those patients that received blood transfusion as well. So regardless of whether the kidney worked or not, patients lived longer if they were given transfusion. So just to finally return to Mr. O, so over the last, fast forward a couple of years, he remained on dialysis. He was coping on dialysis. It's not something that you enjoy, but he didn't have many admissions. He tolerated dialysis. So he had his first fistula formation in October 2017, second stage in January 18, and started hemodialysis in April 2018. And he was activated on the kidney transplant list and put on a regular exchange transfusion from his hydroxycarbamide in October 2018. Remained quite well on dialysis until just a few weeks ago, he received a cadaveric kidney transplant. He's now off dialysis, he's got good kidney function and is doing really well. So just to conclude, sickle cell nephropathy, it's quite common. It's a significant complication of sickle cell disease, and although most patients don't progress to end-stage kidney failure, it is becoming more common, particularly as people age. Moderate to severe renal impairment is associated with a markedly increased risk of dying early. And we know that patients should be monitored for protein in the urine. Their kidney function should be monitored. And for those patients that do develop protein in the urine, we start them on ACE inhibitors or ARBs to slow the rate at which that damage is occurring. There is anecdotal evidence and some trial evidence that both hydroxycarbamide and blood transfusion can be beneficial in stabilizing deteriorating renal function. And certainly in the Mr. O, who I talked to you about today, it really had a significant impact on him. And we really push for early transplantation because outcomes on dialysis are not good. And certainly at King's, we start patients on regular exchange transfusion when they go on the waiting list for a kidney transplant, and we continue it after transplant for as long as the graft survives. So thank you very much. I'm happy to take any questions.
There are a couple of questions in the chat. One from Indu Thakur in Cardiff about the potential role of voxelotor in sickle nephropathy.
It has been discussed. There may be some potential benefit of it, but that hasn't been subjected to any clinical trials as yet in patients. I think there are some animal models in which it's shown to be beneficial, but there's certainly, I'm not aware of any clinical data yet, but it's exactly one of those kind of medications that ought to go into a clinical trial. Every time we have a new disease-modifying medication, we need to be thinking about these chronic complications.
Yeah, I think GBT, the manufacturers, are looking at clinical trials of voxelotor in sickle nephropathy.
Yeah, the problem with chronic kidney disease trials is it can take a long time for chronic kidney disease to progress, and so sometimes trials can be quite long, over a long period of time. You can use surrogates by looking at whether protein levels are reduced, but that is, at the end of the day, it's only a surrogate for kidney function. So you have to have a company that are quite willing to invest a lot to do a clinical trial to see whether their new drug is going to impact chronic kidney disease.
Thanks. Another question from Sandra Suttil about the potential role of cystatin C in monitoring in.
So sometimes, so for those that may not know, so creatinine, as I said, can be excreted by the proximal tubules in the kidney, which means it's not a very good marker of chronic kidney disease in patients with sickle cell disease, because what we want is a substance that's only filtered at the glomerulus and not further secreted by the tubules. Cystatin C is an alternative molecule that's produced in patients, like creatinine is, that is purely filtered. It's then taken up by the proximal tubules and broken down, but it is a molecule that's only filtered, and so there is some potential for it being a better marker of renal function in patients with sickle cell disease. There have been some small-scale studies to suggest it's better, but again, there hasn't been a large-scale study where you compare cystatin C and creatinine to a gold standard measured kidney function to really know the answer to that. And unless people are sort of familiar measuring cystatin C and getting used to it, what's more important really is that even if creatinine is not a great marker, you can still use it to look at trends in individual patients. So if the creatinine is changing, that's what's important rather than the absolute number.
Thank you. And a question from Justio de la Fuente.
Thank you very much. I was going to put two questions, and Claire, I am so delighted that even though you work in adult nephrology, you went down in age to the very beginning. It's fantastic. The first one is that, can you identify a marker, reliable marker below the age of 10 at a point where there is still reversibility for the kidney damage, so that we could select patients who may benefit from bone marrow transplantation?
That's a really good question, and I think the answer is that we could if we did the study. So one of the studies that I've been trying to get funding for really is, does hyperfiltration always lead to proteinuria, albuminuria, and does everyone that develops kidney failure always have it preceded by proteinuria, and that always preceded by hyperfiltration? So although that's the story I've given, we don't, and that's the logical pathophysiological pathway, we've never really proven that. If you can prove that hyperfiltration, because almost all children have hyperfiltration, so which subset of them develop proteinuria and then which subset of them develop chronic kidney disease is difficult. But if you could demonstrate that one always leads to the other, then you can pick a point in that pathway where you deem it's appropriate to intervene with an ACE inhibitor. So you could say, for example, everyone with hyperfiltration could get an ACE inhibitor and you'll benefit 1 in 100 people, say, or 10 in 100 people. If you wait until everyone's got microalbuminuria, you'll benefit 10 in 50. If you wait till they've got macroalbuminuria, you may benefit the majority of them. So it's that balance between the downsides of taking a medication, which is well tolerated, but that there's no medication without side effects or burden, versus the number to treat to get benefit. Does that answer your question?
Yeah. And then the second question is that presumably there is, even if it's a very small amount, there will be the occasional person who may present with this with a type of disease that requires intervention in the teenage years. Mm-hmm. And it's so for those of us who work mainly in pediatrics and who are not as aware as the adult hematologists, could you give us a cutoff point at which we should be starting an ACE inhibitor? And when do you use an ACE inhibitor and when do you use an ARB?
So the studies on when to start an ACE inhibitor, I think, are all done in adults, I'm afraid. And most of the studies were done with PCR rather than ACR. But I think you'd need a slightly lower threshold in a child, but I would still probably pick an ACR of 50, because you're going to have lots of children with ACRs of sort of 10 or 15 that may never get worse. That's a low level of albuminuria. And again, it's that whole benefit of treating versus burden. So I would say an ACR of 50, because that's demonstrating that it is progressive. And it's unlikely to be orthostatic. So some people get a bit of protein in their urine just by standing up, but it doesn't go that high. So I think an ACR of 50 is where I would go for. There is no difference really between ACE inhibitors and ARBs. They both work as well as each other. Studies have shown that in head-to-head studies, they're as good as each other. Both cause hyperkalemia, which is the rate-limiting thing. And studies where they've been combined have shown increased death through hyperkalemia. So they're not recommended to be given in combination, although we now do have potassium binders. So people with rapidly progressive chronic kidney disease who would really benefit from both an ACE and an ARB, we now can give both and give them a potassium binder, or at least give a high dose of one, a potassium binder. But that's definitely the other end of the spectrum. People tend to go with ACE inhibitors first because they're cheaper, and you will swap to an ARB if they cause cough. About 10% of people get a cough on an ACE inhibitor, which they don't on an ARB.
Claire, could I ask you, you identified risk factors related to the Sickle phenotype for development of chronic kidney complications. And there were two separate groups, the patients with a very hemolytic phenotype and those with more typical frequent vaso-occlusive events, who tend to be different patients.
Different patients, yeah.
And I wondered is there any evidence of any difference in the natural history of nephropathy between those two Sickle phenotypes?
Yes, so the ones who are particularly hemolytic tend, as you say, not to have frequent painful crises. They tend to have slowly progressive chronic kidney disease. Their proteinuria gradually increases, their GFR slowly declines, and they end up on dialysis at the end of a long and predictable pathway. Those that have VOC tend to get acute kidney injury when they come in for admission, and those are the ones in whom getting the hydroxycarbamide in there as early as possible can prevent those painful crises. And if you prevent those AKIs, then they're much less likely to progress.
Yeah, thanks. And do you have any recommendations on the duration of exchange transfusion post renal transplantation?
Until they go back on dialysis, or until for the rest of the life of the transplant.
So they should continue indefinitely. You wouldn't consider stopping it after an interval.
So you could, obviously there's all sorts of things that feed into that decision. So there's access for exchange. Usually if someone's had dialysis, hopefully they'll have a good fistula. I tend to try and get fistulas into people as early as possible. I would push for fistulas in people on exchange blood transfusion who don't have chronic kidney disease, for example, because I think lines are really bad things, even in children or young adults anyway. But you have to have the access. You've got the ferritin build up, but a bit like stroke, I don't think it's disease modifying. I think it's just disease prevention. And if you stop the transfusion, you're going to go back to the risks that you have without it.
Yeah, I ask really because we've got an increasing number of disease modifying therapies now in sickle cell disease with crizanlizumab, and as you say, transfusion is not without its potential problems, including alloimmunization and overload. So, but your recommendation would be to continue exchange transfusion indefinitely, providing there are no barriers.
As things stand, obviously, if a new disease-modifying drug changes that, then yes, that's great. You need to disease modify. The crizanlizumab, there was a trial looking at proteinuria. We had to stop it early because recruitment was very difficult, and we haven't got the data on those patients that have been recruited yet to know. But I think crizanlizumab will work in a way reducing those painful crises. Hydroxycarbamide can interact with the immunosuppression post-transplantation. So if someone's prone to a low white cell count, combination of mycophenolate mofetil, which they have to take after their transplant, and hydroxycarbamide can be very difficult to manage.
Yeah, thanks. I just had one other question relating to the figures you showed about how many patients with sickle cell disease receive transplants compared with the general population. Was that in ethnically matched controls, or was it in all transplant recipients?
I think it was in all transplant recipients, but it was also in America. And our data, sickle cell disease is not an independent diagnosis on the UK Renal Registry, so it's quite difficult to get those data nationally in the UK, although it probably would be manageable.
In ethnicity, in terms of proportion of patients who receive transplants in the UK?
It is, Black patients do wait slightly longer for transplants because well, there's the getting activated on the transplant list in the first place, which there's a big push for, and then there's getting a matched kidney. But because the whole waiting list thing is blinded to that, it's not so marked as it might be in somewhere like the United States.
Yeah, thanks. And then there's a question from Josue about why fistulas are superior to other forms of permanent vascular access.
So permanent vascular access, lines are not permanent vascular access.
For example, a port or a Tessio line.
So a port and Tessio line are both plastic. They cause marked stenosis of the vessels that they're in. They have infection risks, so they get a high increased rate of blockage. They tend to work quite well in children that have healthy vasculature, but once you get into adulthood, having a line for a long time can cause you to lose all of your central veins. And then once you've lost your central veins, it's very difficult to make a fistula. Whereas a fistula is only native tissue, and if it's only being needled once every 4 to 6 weeks, it has a really, really long life expectancy, very low rate of infection. In our dialysis patients, the evidence is so strong for fistula versus line that the government actually penalises us financially for dialysing people on lines. So the children tend to tolerate them quite well, but actually, if you're going to be on exchange transfusion for life, you will eventually become an adult, and then lines become really problematic. And I've seen patients have femoral lines, repeated femoral lines, groin scars, really invasive, horrible procedures to go through, whereas a fistula is so easy to make and can last for such a long time.
We've referred a number of patients for fistulas, but these would mainly be adults in their sort of third or fourth decade of life, and very often vascular surgeons find it's not possible to fashion a fistula because their veins have been so badly damaged in the preceding years. Is that a problem that you see more in this patient group.
Absolutely. That's why it's that, if you've got a 18, 19, 20-year-old who's on transfusion for stroke prevention, and they're going to be on transfusion for a long time, put fistula in them. Or give them the choice. That's my argument. Don't do it to them, but let them know that it's an option.
Thanks very much. So if there are no further questions, it just remains for me to thank you on everyone's behalf, Claire, for that excellent, really informative talk, and I hope we can invite you back at some point in the future to update us.
Thank you very much for inviting me. I really enjoyed it.